there's no guidelines for how often people need to have a bone marrow biopsy. The only times I recommend it is if I see a alteration in the blood count that's unexpected. So for example, let's say somebody's on a stable dose of interferon, and they've been taking interferon for a long time, and things have been really stable. And then I see, for example, their platelets drop by 25%, and that's consistent, or I see a decrease in their white blood cell count to a point that is just surprising. In that situation, I would assess the bone marrow, because my concern is always, is there something different happening with the disease? The turning point between something chronic and not dangerous and something a little bit more aggressive is best diagnosed from the bone marrow biopsy.
Is endometrial cancer an increased risk with women with MPNs?
So I would say endometrial endometrial cancer specifically, I don't know that it's known, but we do know from some large epidemiological studies that there is an increased risk of other malignancies with patients that have chronic inflammatory conditions or that have an MPN. So I don't know if anybody else has anything to add specifically about that.
I actually did a lit search on this specific topic, and that's what I presented last time when we had the same meeting. And there are, as Dr. Hobbs said, there are registry data that come from Sweden and many other countries that looked at the prevalence or the incidence, if you will, of other malignancies in patients who have MPN. Now, I realize the older we get, the higher the likelihood that you're going to get cancer, obviously. But it would appear that maybe there is a slight increase in risk of lymphoma that was reported. And then I think someone mentioned kidney cancer, but I think this was prior to JAK2 days, and it may have been actually because you had an EPO-producing tumor, essentially, so that may not have been truly an MPN. So that's what I know.
I would echo both of those. I've wondered too, because I've seen some patients who have family histories of breast cancer who also have developed MPN. So we've looked in our database to try to understand if there's an association, or if, like, BRCA-ness, having the hereditary breast cancer lesion increases risk of MPN. And I think the bottom line is there's not a strong signal, but again, everything is personal. So if someone's asking, particularly because they have a family history of endometrial cancer or they have a particular concern about that, you should follow those guidelines based on your family's cancer history.
This also just reiterates that we want everybody to get your mammograms on time. People need to get their pap smears. People, if you have a history of smoking, you might want to talk to your doctor about whether or not you should get a CT scan, because we just want to be particularly vigilant. Colonoscopies when they're due, that kind of thing. And certainly if you have abnormal uterine bleeding, that's something to be investigated. All those things, we just want to be especially vigilant about normal cancer screening.
We get this question all the time, and that is, how can I tell the difference between symptoms caused by MPNs and symptoms caused by menopause? I could talk to you about menopause.
I was going to say, having had one of these conditions, personally, right, really confounding.
When your doctor says, do you have night sweats? They're not talking about you waking up in the middle of the night a little warm with a clammy neck. They're not talking about a sense of heat that washes over you any time of day. They're talking about night sweats, which are you wake up and you are wet. You have to take off your pajama top and you can wring it out. Your bed is wet. That's what night sweats are. They are not subtle. They are quite significant. Now, that doesn't mean that having a chronic inflammatory state like an MPN doesn't make you very sensitive to the heat or the cold. And people can feel a sense of basically a heat and cold, like a hypersensitivity sometimes I see in my patients. And I don't have any explanation for that. And then you pile on the fact that when people go through menopause, they often have changes in their heat and cold tolerance. In patients like this, I always check their thyroid. You want to make sure you're not missing something easy that you can fix, right? But you can't fix menopause. We don't recommend hormonal replacement therapy for individuals with myeloproliferative neoplasms because of the concomitant risk of other cancers, but also because of the bleeding risk and clotting risk associated with HRT. There are alternatives to treating the symptoms of menopause. There are antidepressants that can be very effective for certain symptoms, and you can use effects, or I guess you would count as an antidepressant. But there are other symptoms or other ways to kind of manage it, including local applications of things if there's problems with vaginal dryness or that kind of thing. But in general, we recommend against hormone replacement therapy. The fatigue, the headaches, who knows? Sometimes it's MPN, sometimes menopause, sometimes it's both. I generally recommend conservative measures for those things because they're not going to limit your life as much. We just try and figure out from a quality of life standpoint.
And also foggy brain.
No, and this is why Dr. Michaels is a fantastic physician, right? We all need to hear this. I think I just also want, with the group, I told you the median age at onset of MPN for women is 48, and the average age of menopause for ladies in the United States is 50.4. So there's a big coincidence here of both conditions, and so it is very confounding because on average most women are dealing with both processes within a couple of years of each other, and so it does really make women have a lot more symptomatology on average.
I will tell you one other thing. Again, I don't have a white coat on, so I don't have to take responsibility if this isn't supported by data, but I'm a big fan of trying changes in your diet, your sleeping habits, and meditation, because those things have zero side effects. If you say, well, look, I don't feel well when I eat a big lunch with a lot of sugar, I say don't eat a big lunch with a lot of sugar. You know, try a month where you give up soda. Try a month where you give up sugar. Try a month where you give up wheat and you just eat, lean proteins, vegetables, because that has zero side effects, or almost zero, and if you feel better, you feel better. And so I also recommend experimenting with different exercise patterns. Maybe you're going to walk in the morning, or maybe you're going to swim in the morning, or maybe you're going to do it before you go to bed because you sleep better. Just try those things out. And then I'm a huge advocate for guided meditation or the relaxation response. So 20 minutes once a day, you sit someplace quiet. There's plenty of apps out there, YouTube videos, or there's a book called The Relaxation Response. That intervention has good randomized data for depression, a good randomized data for hypertension, and again, very low side effects, and it's been around for generations and generations. People have known that if you sit quietly and breathe, you get better. So I'm a big advocate for that.
Okay, Kathleen, I'll do that, I promise. These are great questions. Okay, ladies, in this case, ladies, what do you know about the impact of MPNs to osteoporosis, and what about taking estrogen?
Well, so in terms of answering the second question first, this is true of young women taking oral contraceptives and also hormone replacement. Because of the increased risk of blood clots with MPN, I generally do not recommend that patients take hormone replacement therapy, in addition to the fact that it increases the risk of other cancers, such as breast cancer, after menopause. And then for younger women that are looking to take oral contraceptives, if they're able to take or tolerate progestin-only oral contraceptives, that's my recommendation, to prevent blood clots, because taking oral contraceptives, regardless of an MPN diagnosis, increases risk of blood clots by a little bit. In terms of osteoporosis with MPN, I have to say that I don't know of any direct link with having an MPN and also having osteoporosis, but as these diseases are diseases that can occur in patients that are at risk for having osteoporosis, I'll go back to what I said before about the importance of having a good relationship with a primary care doctor that does that type of screening to make sure that if you do have osteoporosis, you're on proper therapy. Vitamin D is all the rage now, and I don't think there's anything wrong with taking vitamin D, but certainly if you have osteoporosis, you may need other therapies to improve that. I don't know if anybody has
Yeah, I'd echo all of that, and also ask Jamil. In my research into we talk about the bone disease a lot in MPN, particularly the myelofibrosis and osteosclerosis. But if anything, if that develops, it's actually bone hardening as opposed to bone thinning. So it's a great question. I have a bone marrow disease. Does this also mean that I'm going to be at increased risk for osteoporosis, which is thinning of the bones and early fractures? And that's actually not an association with MPN. Now, unfortunately, in an individual, maybe they have a family history or a risk factor for osteoporosis that's independent of their MPN. I'm just saying, so every patient's got their unique risk factors, but in general, MPN doesn't increase risk of osteoporosis because of the bone marrow disease. So, so that's one benefit of having an MPN. Maybe it's hardens, protects your bones a little bit. The other about using estrogens to, to combat menopausal symptoms, and there's been so much research in this, and I think when you're not feeling well, and whether because you're having menopause-related symptoms or your MPN symptoms or both together, there's, you want this fixed. And I think estrogen replacement therapy for menopausal symptoms, the only thing that it's really ever been shown to address is the vasoactive. It does not address well fatigue, bone loss even, cardioprotective, right? And so again, for all of us in the world of being a woman and how safe or useful is estrogen replacement therapy, it does have certain indications, but I just want you, if you've been to a menopause seminar, which I've been to several, but that's a message that estrogen replacement therapy is not going to thicken your hair or improve your skin. All the things that are burdensome problems, it really only helps with hot flashes, and we really need to look at these other therapies for menopausal symptoms.
100% concurrence with everything that was said. Yes, osteosclerosis, but I think it's very important for everybody to receive individualized therapy. That to me is most important, for the doctor to know exactly what your family history like, what your medicines are, what your risk factor is, not just for osteoporosis, but for everything else, in terms of cancer. And you have to be diligent, and I think it was already mentioned in terms of doing age-appropriate cancer screening. So everybody is different, and everybody is individualized. But yeah, I'm not sure that there's actually any association, at least epidemiologically, with osteoporosis that I know of. Yeah.
Just on birth control, a couple of things. First off, the IUD is actually, I think, underused in younger people as a birth control method. It's much safer than it used to be, and I don't think the amount of hormone that's released from an IUD is risky, so that's something that I also bring up to younger women who are looking for a long-term stable birth control without being exposed to hormones, just as an FYI.
So we'll do 2 more questions, and then we'll hear from Dr. Shimon. Are migraines a symptom of MPNs?
They certainly can be. Migraines can be a manifestation of microvascular disease, and that's just like we talked about erythromelalgias or that itching, burning feeling in the extremities or the hands. Migraines, if they're very severe, they sometimes prompt me to think about cytoreductive therapy in people because it's a significant complication, but I usually try and see if we can control them without cytoreduction, like hydrea interferon first. There's new therapies for migraines out there, so the old medicines, which can be very effective. I have terrible migraines. I take sumatriptan. It works beautifully. However, there's new ones also. Botox, a very effective treatment for migraines where you do cutaneous injections of Botox, and there's now some long-term injectable therapies. So if you can control your migraines without cytoreduction, I tend to veer on that side, but it's a debate with a patient.
And I think that to just add to what you said, that adds to other questions about symptoms. Sometimes it's just so difficult to know if a symptom is related to an MPN or not, because so many of the symptoms of MPN can be due to a variety of other things, right? Fatigue can be due to so many different things. The hot flashes, which may or may not be related to menopause. Or I have some male patients that have symptoms that for all the world sound like hot flashes. And same with headaches. I think here's where it's really important to have some individualized therapy, like we've been saying. It doesn't almost necessarily matter what is the cause. What matters is that it gets better. And so that's why it's so important to have a relationship with a doctor. They can try some of these things. And I would say some easy fixes are just kind of maximizing everything else that you can maximize. So even if that hot flash symptom is related to your MPN, or even if that fatigue is related to the MPN, or even if the headache is related to the MPN, if there are things that you can do to kind of maximize all of the therapy so that you don't have to have cytoreduction, that's really important. And so, for example, like with fatigue, and like Laura was saying, making sure that you go to sleep and wake up at the same time, that you exercise and do all these other things to improve your energy in ways that you can. I honestly can't overemphasize that enough.
Okay, last question for this little panel here. Is there anything I can do about the lack of my libido?
I have no idea. There's no good clinical trials on this. There's no interventions. One thing I would say is if it's related to, if you're in a postmenopausal state or a perimenopausal state, ask your doctor about topical estrogens, for example. If this is due to pain with intercourse, there are treatments for that you can have without getting systemic therapies. I would say work on your fatigue. I would say work on anything else outside of the MPN that might be controllable. But it stumps me, and yet it's something that comes up. When you ask patients, it comes up. Some people don't talk about it, but then when you ask them, they say, yes, this is a problem, both male and female that walk into the office.
At our last Women in MPN, was it in New York in 16?
Yes.
Yeah. Ellen Ritchie, who was unfortunately supposed to be here, gave a really beautiful, and I don't know if that's
it's on her website.
Talk about sexual function and MPN, and where she reviewed all the literature, what literature there is, but also addressing many aspects of the disease and how that influences your libido and sex drive. So I hate to say go to the internet and watch this, but it really, it was so well done, and I learned a lot from it. I think another, you might find this funny, but I think in terms of visualization, when you have libido, and libido is down after pregnancy and childbearing and moving into a new home and even marriage, new marriage, like so many things influence libido, and then having the stress of chronic disease. And so these techniques that Laura's talked about in terms of stress management, addressing depression, these all influence that aspect of our lives. And my final thing is you have to use it. If you don't use your libido, you lose it. Well, no, but that's a funny thing to say. Like, it's one thing to say, well, I'm just not interested because, I'm not good at it or I don't have an interest, but, you have to practice to get better. And so I would make that also a recommendation.
Okay, thank you very much. And you can go on the MPN advocacy website and see Dr. Ritchie give that presentation in New York. Thank you very much. And again,